Welcome, everyone. Fantastic to meet you all today, and welcome to the Association of Physicians webinar series on methotrexate. So this webinar today will give you an up-to-date overview of recent research findings that have investigated how to improve methotrexate treatment response and predict who will experience side effects. I'm joined by two superstars in rheumatology, Professor Verstappen and Dr. Plant. And I just wanted to give you all a brief overview about our centre. So the Centre for Musculoskeletal Research is based at the University of Manchester. And we like to think we're one of the most successful musculoskeletal research groups in the UK. And our aim is to invest in research to improve the lives of patients with musculoskeletal conditions. We have a number of very experienced PIs within the centre. And I'm just going to pop our website address in the chat so that if you are interested in collaborating with us or getting in touch, please do, because we'd love to hear from you. So just in terms of some ground rules, this is a webinar series. We're going to move ahead with the three presentations and then lead to a panel of discussion and questions and answers. So you should hopefully see in the bottom a question and answer panel for you to pose questions. Please do keep yourself muted while we're talking, but at the end, it would be lovely to hear from you if you'd like to unmute yourself. So I shall get started with the first presentation. Wonderful. So medication adherence and a spoonful of sugar. So I'm going to give a broad, brief introduction into inflammatory arthritis and adherence, adherence in inflammatory arthritis, biochemical adherence, and more importantly, what we can do with all this knowledge to improve adherence. So inflammatory arthritis is, as many of you will know, a chronic inflammatory autoimmune joint disease where the immune system attacks the joints. It includes rheumatoid and psoriatic arthritis, as well as many others. It does affect the joints primarily, but other organs can be affected too. And it's very heterogeneous, so patients can vary in their presentation from just one joint affected all the way to very severe erosive joint disease. And it is a common disease. Rheumatoid arthritis alone affects 1% or 1 in 100 of us. What I'm really pleased about in terms of rheumatoid arthritis is that we now have a greater understanding of the disease pathogenesis, which has led to this explosion in treatment options for patients. However, I think it's fair to say that medicines will only work if we adhere to them, and patients do need to adhere to medications in the long term. We can't yet cure these illnesses, but we aim to control them with these medicines. Our first line drug is methotrexate. We know that more patients take methotrexate than any other disease-modifying anti-rheumatic drug. It's been proven to show long-term effectiveness, and it has a positive benefit to risk ratio. And it's often co-prescribed with biologic DMARDs, so those more effective but expensive medicines that are more targeted. However, with methotrexate, all of our drugs, we see that response is not universal. For methotrexate, about half of patients with early rheumatoid arthritis will experience non-response. Non-response is multifactorial. Clever people like Dr. Plant look at genetics, environmental, clinical, but it's also behavioral. It's fair to say that if we don't take our medicine, we're not going to respond to it. Adherence, the definition of this is the extent to which a patient acts according to the prescribed interval and dose of a dosing regime. So it's not just whether you take your medicine on time, but also that you take the correct dose. And non-adherence can be intentional or non-intentional. There's many non-intentional reasons, and these perhaps are the majority of reasons for non-adherence. So this includes physical barriers, just not being able to open the pill cap. The pharmacy has run out. Forgetting to take your medication is non-intentional. having the barrier of prescription costs or perhaps difficulties understanding the instructions. Methotrexate is a once weekly drug. Other medicines may be every 2 weeks. Other medicines would be once a day, twice a day, 4 times a day. There's a lot of complex medication regimes out there. But there's also intentional reasons for non-adherence. So this includes treatment necessity. How important is it that I take this medicine? How effective is it? And then balancing that with concerns of side effects, which helps to balance in everyone's mind whether I should take this medicine and whether I should continue taking this medicine. Now, if we focus just on concern of side effects, there's a myriad of potential side effects. This is just taken from the methotrexate information leaflet. And a huge section is based on this in the information leaflet, but very, very little is based on how necessary the medication is or how effective it can be for patients. So when they're faced with this information leaflet, it's very much balanced towards this could cause a lot of side effects, and some of which can be serious. And then when we go to the World Wide Web or the Wild West, we see lots more comments. So even the smallest dose can give you chemo symptoms. It completely destroyed my eyesight. And sometimes hearing about other people's experiences of medicines can be far more powerful than to help you make that decision of your concern or necessity, compared to receiving that information from a medic who's never had to take it in their life. Chemotherapy, I wouldn't be able to drink alcohol at all. I think it's like poison. It's very toxic. And I kept getting pneumonia. And this leads to what we call confirmation bias. So when we speak to patients, we as clinicians will have our pre-existing beliefs about these medicines based on our own experiences, but patients will as well. And confirmation bias is where we seek, interpret, and recall information that confirms these existing beliefs. We might have read some of these things on the internet and then gone to the leaflet and seen that it's in there, and then it's built up on our concerns about the medicine. So this really does tip that balance for the treatment necessity. Yes, it's important that my rheumatoid arthritis is under control, but I've got really high concerns about this medicine. And it's very much influenced by cultural, social, but also healthcare interactions. And we have a lot of the part to play in this. But apart from that, I'd like to also introduce you to NRAS, which is this fantastic charity that helps for peer support for patients who are new to rheumatoid arthritis. So it does include peer support for patients so that they can talk about and help balance against those people who have had negative effects from treatment, which is possible because there's always the possibility of side effects, but it helps to balance that out. And sometimes those people who have had negative experiences can be the strongest voice. So please do have a look at this website and consider signposting your patients to it. So this is take-home message number 1. There's a number of reasons for non-adherence, but the majority of them very much are non-intentional. And we need to therefore look at the system that plays a big part in this and look at how we deliver healthcare, which I'll come on to. So adherence in inflammatory arthritis, how big a problem is it? So this was a systematic review that I undertook with Professor Verstappen and Dr. Hope. We saw that from the literature, methotrexate adherence really was suboptimal, ranging from 59% all the way to 107%. And that 107% represents overdosage, which in itself is a form of non-adherence. We saw throughout the literature that non-adherence predicts response. So it predicts whether your disease would flare, the change in disease activity, so how active the rheumatoid arthritis is, but also radiographic progression. We know that the erosive joint disease is what causes the disability for patients. And we also saw that there's pre-treatment predictors. So unsurprisingly, high belief of necessity increases whether you will take your medicine. So that means that there's a part for us to play to really emphasize the benefits of methotrexate, and also having low scores for depression. So it's important to screen patients for low mood in your clinic. Professor Verstappen will be talking about the RAM study in a bit more detail later, but I just wanted to introduce some work that we did as part of the rheumatoid arthritis medication study. So this was a prospective observational cohort study of patients newly starting methotrexate with rheumatoid arthritis. We sent patients diary cards to ask them when they took their methotrexate. And we had over 600 diary returners, which was fantastic. Despite the fact that the adherence was being monitored, so you had a diary, you ticked whether you took your medication or not, which in itself helps to remind you to take your methotrexate. We still saw that 1 in 4 patients were non-adherent to their medication. A lot of that was intentional in nature, and fear of side effects or the development of side effects was around 1 in 3. We also saw some predictors of non-adherence being those patients with higher concern. So this maps back to that scale and how we tip the balance between necessity of taking your medication versus concern and fear of side effects, and also higher fatigue. So take home message number 2, non-adherence really is the norm in our patients and in ourselves. I don't think any of us can say that we've always followed the rules. So it really is important that we do not place blame on this health behavior, but that we look at non-adherence and open the door to an honest discussion about ways that we can help support patients with this health behavior. So biochemical adherence. So adherence really is difficult to measure. Current NICE guidelines ask us to ask the patient if they've missed any doses of medicine recently. I think it's fair to say that self-reported adherence behavior is often inaccurate and can therefore lead to us, as healthcare professionals, not knowing what the true behavior is. We could also use electronic caps, so a cap on a pill bottle. However, that doesn't mean that someone's taken the medicine. So the cap may be accidentally opened. You might have to open the cap to refill the pill bottle, for example, which would then record it as the medicine being taken. And that figure of 107%, that study was actually one from use of electronic caps. So it may be that there was some instances where there was some pills boxes being opened, but the medicine was not actually taken. We can also look at prescription claims. So we can look at claims for repeat prescriptions from GP surgeries, but this still doesn't mean that you're not going to forget the medicine when you go away on holiday. So these methods of measurement of adherence can be inaccurate, and it leads to the fact that us as healthcare professionals are often unaware. So it's really difficult for us to have those open and honest conversations with our patients for how we can support them. So biochemical adherence is a direct measure of adherence where we actually measure the drug or its metabolite in the blood. We do this for therapeutic drug monitoring in a number of disease areas and medicines such as digoxin, phenytoin, carbamazepine, where if we don't detect the drug at all, we often think, well, have you taken the medicine? The main advantage of this is that it is much more objective than self-reported, but it can be intrusive. It is expensive to develop. And also, it doesn't get around the issue of white coat adherence. So I give the example often that when people go to the dentist, they'll often brush their teeth. When people go to the outpatient clinic, they may take their medicine prior to having their blood test taken. However, what we did do during my PhD was we developed and validated a methotrexate adherence assay that detects methotrexate within the past 7 days, and methotrexate is once weekly medicine, and this was for oral methotrexate. And it also detects adherence according to dosing level as well, all the way up to our maximum dose of 25 milligrams per week. It's based on mass spectrometry, and we showed from our real-world patient samples that it had a sensitivity of 95%. So we think that it's a pretty good test. So this led us to think about, well, how could we use this test? We can detect it, we can detect adherence, But is there any way to use this to improve adherence? So this led us to use this as an intervention in itself. So biofeedback is a behavior change technique where we provide feedback about the body, such as a biochemical state, such as someone's blood pressure, such as someone's cholesterol, for example. And it's used as an external monitoring device. Your cholesterol is high. How are you getting on with your statin therapy, for example? So this was a feasibility study. So it was to determine whether it's feasible to do a fully powered clinical trial. And this was very well supported by the Association of Physicians, which I'm very grateful. So it was a randomized controlled trial of patients prescribed oral methotrexate with rheumatoid arthritis. At visit one, patients were consented, randomized, and they donated a blood sample to measure their biochemical adherence. 25 were in the control group, and in the intervention group, we phoned those patients with the results of their adherence blood test. And we used that as an opener for a conversation about how people are getting on with their methotrexate. And then 3 months after visit one, we again measured biochemical adherence in both cohorts. So what did we find? Well, adherence can go up and can go down over time. So we found in the control group that adherence did go down from 83% to 69%. In the intervention group, if anything, it marginally improved from 85 to 92%, which is a fantastic number. But importantly, we saw that the change in disease activity, so how active someone's disease control is, didn't change in the control group, but did improve in the intervention group with a change in DAS28 of 0.38. So this has shown an early signal that using this intervention can help to improve someone's disease control. Now, you'd say, well, the adherence was really high in the cohort, but I guess what I'd say is that by having that intervention, it helped to remind people within those 3 months to take their methotrexate every week, once a week. And that might be why we saw the intervention group improved in their DAS28, whereas in the control group, they didn't have that blood test to act as a reminder to take it once a week and on time. One of the big concerns I had as a clinician was whether this would break down the physician-patient relationship. So for 9 patients, we had a qualitative semi-structured interview. The interview was undertaken by a person who was not part of their clinical team. What we saw was really high engagement from the patients who took part in the study. They were very supportive of the blood test and the trial process overall. And we also asked a questionnaire, so we got a figure that 96% agreed or strongly agreed that it was worthwhile to take part in the study. So I think that that's really positive news from that. So that leads me to take home message number 3. Adherence can be improved by behavior change techniques. And we've seen that it doesn't break down the patient doctor relationship, and that patients are very engaged with the use of that. So that's fantastic. And it's helpful to use it really as an opener for that honest discussion on things that we can do to help improve adherence. And there's lots of potential things which really do need to be tailored to the individual. Someone who is of working age will have different needs compared to someone who is older with a complex medication regime. So here's my top tips. I think it's really important that we have a team approach, that patients don't have mixed messages about their methotrexate treatment, and that we emphasize the benefits of their medication whilst giving balanced views of side effects and looking at absolute risks rather than relative risks of developing risks of side effects. We should all review our patient-facing material to look at this, but also our healthcare system. Methotrexate requires regular blood monitoring. If patients aren't able to book in for that blood monitoring, how can they be adherent? And then what we'll see is that patients have worse disease activity, and they need to escalate to the more targeted therapies that are more expensive. It's really important that we have blame-free consultations. None of us can say that we're adherent to everything all the time. And do explore with your patients that balance and that scale between how necessary they view their medicine and any concerns that they have. So thanks so much. That's I'll stop sharing, hopefully. Wonderful. That's the end of my talk. And please do pop any questions that you've got in our Q&A section. But now I'm really pleased to introduce Dr. Darren Plant. Darren, are you there? Fantastic. So Dr. Plant is a senior lecturer at the Centre for Musculoskeletal Research. He's been involved in several large national and international collaborations, including the Versus Arthritis MRC Joint Funded Mature Programme and 3TR. And he's extensively published over 80 original articles and has a H index of 41. So welcome, Darren. Great to see you.
Thanks very much, James, and thank you for the invite. I will attempt to share my slides. Give me a second. Can you see that in the right?
It's not presenter view.
Does that look right?
No, that's presenter view. Wonderful. Thanks, Darren.
Okay, fantastic. Thank you. Just move everybody's heads out of the way. Okay, thanks very much. So in the next few slides, I'll just share with you some recent research that we've done in Manchester predicting drug immunogenicity to tumor necrosis factor inhibitors and in patients with rheumatoid arthritis. Tumor necrosis factor inhibitors are the most commonly and widely used type of biologic drug for treating immune-mediated diseases, including rheumatoid arthritis. And they're very effective for a large number of patients. However, repeated use of TNF inhibitors, can lead to the development of anti-drug antibodies. And we refer to this as anti-drug antibody development or immunogenicity. And that's where the patient's own immune system has a response towards the treatment, which can result in lower circulating drug levels, secondary loss of therapeutic response, and poor drug survival. Anti-drug antibody development is an issue for monoclonal antibody-derived TNF inhibitors, really. So the ones listed on this slide, they can develop at any time. They can be transient, but typically, I think it's fair to say that clinically relevant anti-drug antibodies develop during the first 12 months of treatment. We do know that co-treatment with conventional synthetic disease-modifying anti-rheumatic drugs can delay time to developing anti-drug antibodies, but we don't fully understand the molecular mechanisms underpinning immunogenicity, why patients develop anti-drug antibodies and why some patients develop anti-drug antibodies earlier than others. So that's the knowledge gap. Several research groups have tried to address that knowledge gap by investigating potential genetic predictors of anti-drug antibody development. And typically these studies are focused on chromosome 6 in the HLA region. This is a region of the genome where there are lots of genes that are important to immune responses and particularly to antigen presentation. In the table on this slide, I showed you 3 studies that have recently been published in rheumatoid arthritis and also in IBD. You can see that the studies are quite different. For example, the drugs that have been investigated, the duration of the study and so on, and the sample sizes. But you can see that some of the genes overlap between IBD and RA, for example, DRB1, the gene HLA-DRB1, particularly the O3 allele. And I'll draw your attention to the last row of that table, really. That's the study in IBD, where over 1,200 patients were included in that study. So that's the most powerful study to date with the most compelling evidence for a genetic association with anti-drug antibody development. And that was observed at the HLA-DQA1 gene, particularly the O5 allele. And that genetic effect was observed with genome-wide levels of statistical significance. So because of the decent sample size there. But there are differences also between the studies, and some of those differences are likely to result from differences in study design. Some of those differences are listed on that slide. What we wanted to do was to try to add support for some of these genetic loci in rheumatoid arthritis by providing evidence of validation for some of those genes that have already been identified, and also potentially identify some new genetic effects. And in order to do that, we access samples from the Bragg's cohorts that's hosted in Manchester. Bragg stands for the Genetics and Genomics, the Rheumatoid Arthritis Genetics and Genomics Study Syndicate cohort. We selected patients from that cohort who were treated with adalimumab. From our bioresource, we took some serum samples from the freezers from patients at 3, 6, and 12 months post-treatment, measured anti-drug antibodies in those serum samples using a commercial assay, and at each of those time points determined whether patients were positive or negative for anti-drug antibodies using the cutoff that was provided to us by the provider of the assay. We genotyped all patients using a commercial genome-wide single nucleotide polymorphism array called OmniExpress that is produced by Illumina, and we used some software to impute HLA alleles from that genetic data set. For the genetic study, we used, and for all analyses that I'll present, we used Cox regression. So we're interested in identifying predictors of time to event in this model, and the event is becoming positive for anti-drug antibodies. For the genetic model, we adjusted for sex concurrent DMARD therapy and the first principal component from the genetic data. So the slides are frozen. This is the patient characteristics for the patients who were in this study. I've added some arrows just to point out a few rows of interest. So in total, there were 445 patients in the study, and during the time, the lifetime of the study, 96 patients became positive for anti-drug antibodies, which is just over 20 or close to 22%. Of the 445 patients, 377 patients were concurrently treated with a synthetic DMARD as well as their biologic drug, their TNF-inhibitor adalimumab. And of those 377 patients that were concurrently treated with synthetic DMARDs, that treatment regimen included methotrexate for 302 patients, which is just over 80% of the patients concurrently treated with DMARDs. The first thing we did was to look at the clinical effects. So what clinical characteristics were predictive of development of anti-drug antibodies? And what we found was, what others have established in the literature, is that being treated concurrently, this is the first row of development, with a hazard ratio of 0.38. If you look at the next row down, the second row, we can see that if that synthetic DMARD treatment included methotrexate, there's a protective effect there with a hazard ratio of 0.41. And in the third row, interestingly, when we look just within those patients that are treated with a synthetic DMARD and compare being treated with methotrexate versus being treated with synthetic DMARDs other than methotrexate, we can see that methotrexate offers a protection with a hazard ratio of 0.43, and that was statistically significant at a p-value of 1.27 times 10 to the minus 5. So methotrexate offers quite strong protection from or reduces the rate of developing anti-drug antibodies. If you look in the fourth row, although the p-value wasn't significant, when we just looked in those patients treated with synthetic DMARD, but excluded patients treated with methotrexate, we also saw protection from or a reduced rate of developing anti-drug antibodies with a hazard ratio of 0.66, but that p-value didn't reach statistical significance. But if you look at the number, the N column, the number of patients in that analysis, it was much smaller than in the first 3 rows, and we suspect that there's an effect of having less power for that particular analysis. The last arrow to point out is the second to bottom row. We did see very modest effects of disease duration. So as your disease duration increased before you were prescribed adalimumab, there was a very modest increase in the risk of developing anti-drug antibodies. This slide shows the results of the genetic association test. This slide really just shows the top 2 hits, if you like, the 2 hits with the smallest, the 2 genes with the smallest p-values. And on this slide, you'll see in plot A and B some results that relate to the HLA gene DQA1, particularly the O3 allele. And in plots C and D, you see the results for the gene HLA-DRB1 for the O4 allele. Actually, the correlation of the R squared between these 2 genetic effects was 0.94, which means that they're very correlated, and actually we'd probably just see one effect here. So if I talk you through the A and B plots first, you can see on the y-axis of plot A, there I am showing you, presenting the percentage of patients without anti-drug antibodies, and across the bottom is the time frame for the study. So what you can see in this plot are three lines. One of them is a blue color, which is patients with 0 copies of HLA DQA103. There's an orange coloured line, and they're patients who carry 1 copy of that allele, and then there's the green line, which is patients who carry 2 copies. So you can see in plot A that patients who carry at least 1 copy of DQA103 are protected from developing anti-drug antibodies compared to those patients who carry 0 copies. So that the rate of developing anti-drug antibodies is slower in those patients with 1 or 2 copies of that allele. So that's quite interesting. There's a protective effect there at DQA103. If we then look just in those patients that carry at least 1 copy of DQA103, so this is the people who fall into the orange and green categories. If we look just in those patients and then have a look to see what the effect is in those patients of being treated with methotrexate, being treated with other synthetic DMARD other than methotrexate, or receiving no concurrent DMARD treatment at all, we can see there is a difference in effect. So even in those patients with the seemingly protective genetic background, there is still a stronger protection from developing anti-drug antibodies in those patients treated with methotrexate versus those treated with other DMARDs versus those treated not treated with DMARDs at all. We see the exact same pattern in plots C and in plots D for the HLA-DRB1 allele. So those 2 results I've just presented are in green on this forest plot, the top 2 hits, but we also had a look at some of the other genes that I showed you in the introduction, where others have reported genetic effects in both RA and IBD, and we also found statistically significant results in the same direction as those original studies for the genes that are shown in this plot. So, for example, the HLA-DQA105 allele that was found at genome-wide levels of significance in IBD, we find that effect in our RA patients as well, in the same direction as that original study. So in summary, this is the largest study of the effects of HLA genetics in anti-drug antibody development in rheumatoid arthritis, the strongest protection from immunogenicity we observed in this study was conferred by synthetic DMARD therapy, and that's particularly for those patients who are treated with methotrexate. But we also did see that there's some protection from developing anti-drug antibodies in non-methotrexate treated in patients treated with synthetic DMARDs where that DMARD wasn't methotrexate. So there is still some protection there. We found modest association between anti-drug antibody development and alleles at the DRB1 and DQA1 genes. We need to sort of continue investigating these signals to sort of further identify what are the particular amino acids that look like they're relevant within these genes, and where those amino acids sit in the HLA molecules. There are some limitations to the study, of course. It's a short duration time. For most patients, that was around 12 months. And we had incomplete sampling, so we measured anti-drug antibodies in 3 time points where we could for most patients, but sometimes the serum sample wasn't available. Even though this is a large study of its type, it's still a small study, really, when investigating genetic signals that can be quite modest. And we took the decision to limit to adalimumab because it's possible that genetic effects are slightly different for the different TNF inhibitors. So that was a sensible approach. But of course, we also now need to understand what's going on in terms of genetics for the other monoclonal antibody-derived TNF inhibitors that we need to investigate. So that is the end of my presentation. Of course, I'd like to make some acknowledgements, and particularly Dr. Chong-Fu Yap, who performed the analysis. Thank you.
Fantastic, really interesting results there, Darren. Thanks so much. Really highlighting methotrexate still being the anchor drug in rheumatoid arthritis. So next is Professor Suzanne Verstappen, who's a professor of epidemiology within our centre. Her main research interests include investigating long-term outcomes. She's the PI of several national and international studies, including the large national rheumatoid arthritis medication study of more than 2,000 patients with rheumatoid arthritis. She is also the lead of several international task forces and working groups. Welcome, Suzanne.
Thank you very much. Thank you for the invitation. I'll start sharing my screen. Okay. Yeah, the focus of this last presentation is on the methotrexate-related adverse events in people with rheumatoid arthritis. As mentioned earlier, methotrexate is the first choice, and it's mainly based because of the low cost and the established efficacy. In a previous clinical trial, the CAMERA-1, where they compared intensive strategy approach where people were seen every month using methotrexate compared to those who were seen once per 3 months, we saw remission rates of about 50% in the intensive group and 37% in the conventional group. But it's always finding the balance between efficacy and adverse events, and especially patients commencing methotrexate are often very anxious about possible adverse events that may be related to methotrexate. Also, methotrexate is often seen as one of the reasons they may discontinue some of the treatment. The study by Holly Hope has been mentioned earlier, and with respect to non-adherence adverse events was the main reason why people were non-adherent, intentionally non-adherent. So it's a really key topic that needs to be addressed in the clinic. But how often does it occur, and can we actually predict some of these adverse events seen in clinic? Just a brief overview of a systematic review and meta-analysis we did. This was done by Ahmed Sabini, who was a PhD student in our center. This meta-analysis shows the total methotrexate-related adverse events seen in clinical trials and in observational studies. So the above studies are from clinical trials, and we took the methotrexate arms and they were treated as observational studies. As you can see, there's a large difference in some of the estimated proportions and prevalence rates across these studies. But also you can see that the number of participants ranges from a very sort of small number from 19 until a couple of hundreds. So the estimated prevalence in these clinical trials was about 80%. But when looking at observational studies, there is much less information available. And the estimate is actually much lower than we saw in the combined clinical trials. For observational studies, the prevalence rate of adverse events was about 23%. There may be a couple of reasons why there are these differences. As you all know, in clinical trials, of course, there's a very stringent way of collecting information on adverse events, and most adverse events will be collected. In observational studies, some of the data may be extracted from medical notes, in which not always all adverse events are collected. If you then actually look at possible sort of reasons for discontinuation, similar meta-analyses were performed, again in clinical trials, separately from observational studies. In here, we see that actually the percentage of people who discontinue methotrexate in clinical trials is about 6.7%, which is lower than seen in observational studies, 15.5%. And that might be because in clinical trials, one may want to adhere to the clinical trial protocol. But overall, about 8.4% discontinue methotrexate due to adverse events. Get a better understanding about what are these adverse events and to really collect some detailed information, not just about the adverse events, but also to look at possible predictors. We set up the rheumatoid arthritis medication study in which we looked at adverse events, response, adherence, as mentioned previously. So this is a large observational study, a 12-month study, and including 38 centers. We have recruited more than 2,400 patients with rheumatoid arthritis or undifferentiated polyarthritis. All these patients were about to start methotrexate for the first time. They could either start in combination with another synthetic DMARD or oral steroids, but people who were on biologics or used biologic before were excluded from the REM study. Detailed information about clinical data, about patient-reported outcomes, adherence and blood samples were collected at baseline, 6 months and 12 months. For the data presented on adverse events in this talk is based on data on adverse events collected at baseline and 6 months and 12 months. So we had a predefined list that was previously used in the Camera 1 study. So just to make sure that we collected the majority of the different adverse events, sort of minimizing the clinical trial setting. We also collected adverse events in the diaries that James mentioned earlier on, where we also collected data on adherence, but those data have not been published yet. So when we start looking at the rates and predictors, what did we find? So in this baseline characteristics, we see sort of a general sort of population of rheumatoid arthritis. These are early rheumatoid arthritis patients with a symptom duration of 7.71. For this specific study, we only included those patients with a disease duration of less than 2 years. Methotrexate starting dose had a median of 15, but we did notice that there was a huge difference across the hospitals or even within the hospitals at the starting dose. Some started at 7.5, some 15, some 20s. And there was a huge difference in how methotrexate was increased during the first couple of weeks. About 24% also used oral steroids, and about 25% also used concomitant synthetic DMARD at baseline. During follow-up, we did notice that the majority were still taking methotrexate at 6 and 12 months. The majority of the patients also started methotrexate orally. About 10% switched to subcutaneous methotrexate at 6 months and about 16% at 12 months. 39% 13.9% were taking other DMARDs at 6 months and 22.8% at 12 months. During the whole period from 0 till 12 months, about 78% of the people reported having at least one of the adverse events. The next couple of slides show the different adverse events that people reported. On the left-hand upper corner in the blue graph, we see the general adverse events. So about 40% of the people reported having one of these events. Most of these reported having some fatigue or general malaise. On the upper right-hand corner in the orange graph, the majority of the people reported gastrointestinal events, which was the major adverse events observed in this study. Of this, nausea and diarrhea were the most common adverse events. In the lower corner, you see the number of patients with cutaneous events. Still about 25% of the people reported having one of these events. Although most of these were relatively low, and about 9% of these reported having alopecia and about 12% having oral ulcers. Neurological events were quite rare, about 27%, and a majority were mainly subjective, including headache. In the next couple of slides, we see on the upper left corner the pulmonary adverse events. About 21% reported having at least one of these events. The majority reported having some cough, about 15%. Pneumonitis was very rare and was less than 2%, which was quite reassuring to notice as well. Hematological adverse events were very rare, again about 5 to 6%, and the majority were especially about anemia. When looking about liver, increased liver enzymes, which is a worry and often monitored regularly during the clinics, we found that about 80% had ALT increased at least once upper limit normal, but those with an increased level 2 times upper limit of normal, again, that was quite rare, about 3%. So in general, there was a huge variation in the reported adverse events that we saw. When we started looking at what these adverse events might be and how they were predicted, what were the main factors to be predicted, we did a number of analyses, including multivariate models. In these models, we included variables which we thought might be associated with some of these adverse events, or which were clinically or biologically relevant. Looking at the first 4 different adverse events, in which we also look specifically at nausea, because this is an important adverse event for patients, we noticed that older age were protective of having gastrointestinal nausea events. However, women were more likely to report all of these 4 different adverse events. If we look at alcohol consumption, there was a slight increased risk for nausea, and gastrointestinal events, but for gastrointestinal events, this didn't reach statistical significance. We don't know why it was also increased in alopecia, and we're not quite sure what the explanation of that might be. BMI was associated with both GI and mucocutaneous events. Then there were a couple of other factors associated with these adverse events. So, for example, in the people who reported gastrointestinal events, there was a huge sort of increased risk for those who had a high concern, coming back to their beliefs about medication again. Methotrexate starting dose didn't really have an impact on any of the outcomes. There was a small trend that those who had higher dosages were less likely to have mucocutaneous events. For the other different groups, we saw some similar findings. Again, older age was especially protective for hematological adverse events. And also being female was at an increased risk for neurological events. There seemed to be some protective effects for alcohol consumption, but again, that was quite difficult to explain why we did find some of that information. Also, there was a relation between kidney failure and hematological events. In here, we did see some protective effect of higher dose methotrexate starting point and concomitant synthetic DMARDs. For the pulmonary events, we also looked whether patients who had asthma or COPD were more likely to develop any pulmonary events, but we didn't find any association. So what does this tell us? That in general, we know that methotrexate-related adverse events are common in people with rheumatoid arthritis. Gastrointestinal systems adverse events are the most prevalent adverse events we observe. Alopecia, which is often one of the worries, especially for women with rheumatoid arthritis, occurred in less than 1.10%, and pneumonitis was very rare. Older age was associated with several adverse events, especially gastrointestinal and hematological events. And whereas women were more likely to report many adverse events compared to men, including GI events, mucocutaneous, neurological, and alopecia. We also did find that those with a higher health assessment questionnaire, a measure of functional disability, was associated with more pulmonary adverse events. One explanation for this could be that those who had already some physical problems, less physical ability at baseline, had also more problems with their lungs already. And this might explain some of the findings we found with this adverse event. So during one of the starting dose did not seem to have a big impact on the development of any of the adverse events. But we also must realize that there was a huge variation in the starting dose, and the change in dose methotrexate was quite a lot across the different hospitals. And many people had an increment in methotrexate dose in the first couple of weeks, which wasn't included in the analysis. The beliefs about medication concern score was associated with both gastrointestinal events and nausea. And this comes back to the first presentation, that talking about these concerns are key in the clinic, and that good communication about adverse events and expectations at the start of methotrexate are key to reduce some of these concerns. And I would like to thank you for your listening to this presentation. Thank you.
So we've got a question. Thanks so much, Lydia. Once patients achieve benefit from methotrexate, if they then start becoming less adherent, do you know how long it takes to relapse to pre-treatment level of disability? And can there be a rebound effect and maybe suffer worse disability from baseline? That's a really interesting question, Lydia. I have no idea. Generally, with methotrexate, we say it takes 3 to 6 months for it to start to work. We can still detect methotrexate within the red blood cells at 6 months after people have stopped it. So how long it takes to relapse to pre-treatment, I don't think that I have an answer to that, unfortunately, but I think that's certainly something we should look at. Thank you.